All right, everyone. So we'll go ahead and get started on chapter 19, Neurological Emergencies, Part 2. This one should be a lot quicker. We're pretty much just covering seizures and headaches, and then we'll talk about the treatments for all these disorders. So let's get going. So seizures, we've probably all seen these in the movies, and maybe you've seen one in person. They are frightening. Let me start with that. Even as a paramedic or an EMT, they can be frightening to watch. But let's talk about what they are and what they're not. Um, Basically, remember all those neurons that we had in our brain, right? And they send electrical signals to communicate. Well, what happens in a seizure is, for whatever reason, there's a variety of reasons why this can happen, is they start firing erratically, right? So instead of just a nice, like, streaks of lightning, right? It's just like a just electricity everywhere, right? And so the erratic firing of these neurons, sending electricity in all these different directions, is what will cause seizure symptoms, okay, or signs and symptoms. And so, there's the seizures again are on a spectrum, right? Like there's this huge, complicated thing that we're actually going to talk about, talking about the different subclasses of seizures. And these are difficult to diagnose. There's tests that neurologists have to do to be able to definitively diagnose these, and it takes a while. But our jobs as ENTs is to stabilize these patients. We'll first recognize it as it's a seizure, stabilize them, prevent them from doing any harm, and transporting them. So, and usually providing oxygen, protecting their airways, stuff like that. So, one thing to know is that these present weird, and I'm going to talk about all this, but it can be limited to just one hand shaking, right? And the patient's like, I don't know why, but my hand won't stop shaking, right? That could be a seizure, right? Or it could be a metallic taste in the mouth. That's usually related to something called an aura, okay, or A-U-R-A, an aura. Or other, it could involve the movement of every limb, or it could, be complete loss of consciousness. I think that's what we tend to think of when we think of a seizure, and I think people are pretty good at recognizing, like, oh wow, that's a seizure, okay. But we're going to talk about these different subclasses, okay. So I have this here that might help you, it might not. This is out of one of my medical school books, but um, basically what we do with seizures is we put them into types, okay. And so we have the what's called a generalized seizure, right? Whoops. We have a generalized seizure. Whoa. We have a generalized seizure, or we have a focal seizure, okay? So, like, if you think of like what the word generalized means, right? It means just like kind of broad, or like a general manager of a store, right? Like they're over the whole store. So, a generalized seizure means that it's across the whole brain, okay? And so that's something to be aware of, right? So, like, generalized seizures are generally across the whole brain, right? Everything gets involved. And so underneath this whole generalized seizure thing, we can have different type of of manifestations, right? So the one we see a lot in the movies where people are tonic-clonic, right? Right? That's a grand mal seizure, right? A tonic-clonic seizure, and it falls underneath the umbrella of a generalized seizure, okay? And so you have this alternating stiffening movement, right? It also looks like what I look like when I dance. And so this whole tonic clonic phase, right? You could know that tonic is when they'll arch the back and extreme and uh, extend the extremities, and then a clonic phase is when they'll come in, right? And so basically they have this rapid oscillation between the two, and to us that looks just like shaking. But realize a seizure could just be straight up tonic, right? And so I've seen this, and it could start tonic and lead to tonic clonic, to where it could just be straight up. They'll just stiffen up, right? And so they could be unconscious or not, but they'll arch their back to where it looks like this, right? Very scary when these happen. And then myoclonic, right? So myo means muscle, right? So this is quick and repetitive jerks. Okay. A tonic, what you have to worry about in a tonic seizure, and they won't test you on this, but I'll tell you know. What you have to worry about in a tonic seizure is someone who's walking, like an adult who's walking, and then boom, they have a seizure. They fall, and they don't catch themselves, obviously, because they've lost their brain and their muscle. So they fall and they face plant or smack their head or wreck their car or whatever. So you have to be worried about, A means without, so without muscle, right? Without muscle tone, atonic. So they fall and they drop to the floor. And then there's this last one called an absence or a petit mal seizure. And so basically, this is where they'll have like this blank stare. Okay, and there's no postictal confusion. We'll talk about what that means. But um, and then as over here on this other side, we have focal seizures, right? So like a focal seizure is just a foci of the brain. So instead of the whole brain sending electricity everywhere, right, back and forth, what you end up with just a little piece of the brain, like a little chunk, like a golf ball sized chunk, for example, could just be having a seizure. So you'll get manifestations. And depending on how big this focal seizure is, it could be bigger than a golf ball, obviously, um, is the more, manifestations you're going to get. So what we do with a focal seizure is we decide if it's like focal aware or focal impaired awareness. A focal aware seizure is they're aware of their surroundings. So again, the person that's just like my hand's shaking, I don't know why, right? That would be a focal aware. They're telling you, I know my hand's shaking, I can't get it to stop, right? Actually ran calls with this, right? Like the guy's arm was just shaking. He's like, I can't get it to stop, and so we obviously took him to the hospital. But that would be like a focal aware seizure. Okay. Now we'll talk about what these other ones mean coming up. So a tonic-clonic seizure, typically this will present with something that's called an aura, and an aura is like a warning, not even a warning. It's like a yeah, a warning's probably another word for it. But what an aura is it's. I'll just tell you what they are, and you can form your own opinion. An aura could be someone that has a metallic taste in their mouth, so they'll tell you like it tastes like I'm chewing on quarters and pennies, right, in their mouth. That taste, it's metallic. Or they'll say, oh no, I'll see like three flashes of light and a dog bark, right? And this is all in their head, and then they know like that's my aura. I'm about to have a seizure. Or they'll see flecks in their vision, or they'll see stars, or their ears start ringing, and they know like I'm about to have a seizure. Okay. Another way this can happen is a change in smell. They'll say that they smell some smell that's very similar. Like they can say, "Oh, I smell bacon," and I'm in my bedroom. I shouldn't smell bacon right now, and they'll know, "Oh God, I'm about to have a seizure." So the aura can be helpful because they can warn people, "Hey, I'm about to have a seizure," and they can also get down to the ground or to safety, pull over their vehicle or whatever. So aura is a warning of a seizure, and we tend to see auras in tonic-clonic seizures. Okay, so it's coming up to a test near you where I give you an example of someone who has a metallic taste in their mouth. What is that called? It's called an aura. Okay, I will test you on that. Now, loss of responsiveness, obviously, in a tonic-clonic seizure, they're not awake. They have no awareness. Okay, so you'll have the tonic phase, the hypertonic phase, the clonic phase. Doesn't matter what those are. And then there'll be post-seizure. Post means afterwards, so after seizure. And then we have what's called the postictal state or the postictal phase. Remember, when the brain's firing 100 times faster than it's supposed to, just electricity going everywhere, and your diaphragm is impaired, right? Because you're not breathing normally in a tonic-clonic seizure, right? Your muscles are impaired. You need your diaphragm to breathe. And all your muscles are using a lot of ATP and oxygen and glucose to do their little jerky movements. Your body feels like it just ran a marathon. And so you're very tired after a seizure. That's normal. And the brain is very, very tired. It's depleted all its oxygen and glucose. So they usually will wake up in a stupor. And they will get better and better as time goes on. And the postictal state should be 5, 10, 15 minutes. 5, 10 is the normal. To where they're going to be very confused in the post-seizure. But in their postictal state, they should progressively get better and better back to normal. Don't rush them through this phase. The treatment in the postictal phase is usually oxygen, because usually they are hypoxic, because they have not been breathing very well for the last several minutes of their seizure, and they have used a lot of oxygen to do what they just did. Okay, so that's called the postictal state. Altered mental status with hypoxia usually. Okay, now there is this annoying condition that we actually run a lot called pseudo seizures. If you don't know what the word pseudo means, it means fake or like false. Okay, so what this means is like a false or a fake seizure. We could simplify this and call it a fake seizure. And so it is a diagnosis, and it's a generalized neurological event, and it may be unnoticed to differentiate from a generalized seizure. So what will happen is this is a psych disorder, okay? So this will be the 22-year-old female who just broke up with her boyfriend, who's in the Walmart, looking at Valentine cards, and decides to pop to the ground and shake for 5-10 minutes, okay? That might sound more like, oh, with no seizure history, right? That might sound a little bit more pseudo seizure in nature. And the thing about pseudo seizures is they almost always will be witnessed, right? And the reason this is psychiatric, right? So it's not fun to fake a medical condition or a seizure. It's a lot of work to fake a seizure. It's not a lot of fun to do that by yourself. So it's almost always in public or in the presence of someone else. That's one, okay? Two, they won't have a seizure history, and they're otherwise generally well. Not that a normal person can't have a generalized seizure, but there's things you can kind of look for. They'll be aware, right? So I've seen people where they're like, "Help, I'm having a seizure," right? And they're like looking at you, or they'll be having their seizure, but they hold their right arm perfectly still when you're starting the IV to give them benzodiazepines, right? And so you'll see things like that come with time. But my important thing is to point out two things. It is still a medical condition. This is a psychiatric condition, right? These people are mentally unwell for whatever reason. Okay, it doesn't make them bad people or stupid or, subhuman. It's a psychiatric condition, just like stress or anxiety or depression or PTSD or OCD or ADHD or whatever you want to come up with, right? This is still a psychiatric condition that they believe to be very real, and we have to treat it as real. And I'll tell you why. It is very difficult for your untrained eye. You're getting one slide in EMT school on pseudo seizures, okay? It's not enough to distinguish the difference between a real seizure and a pseudo seizure. And so just know this condition exists, but we still treat every seizure as a seizure. Your job as an EMT or as a paramedic is not to diagnose pseudo seizure. Your job is to take care of patients and believe them and to be an advocate for them and to honor our profession, right? And so what you need to know is that we have to, I say this all the time, so I spelled it out for y'all. You have to do no harm. We don't want to do harm to these patients. So if we're like, oh, look at them, guys, it's a pseudo seizure. We're not going to do anything, ha ha, right? You just did harm if it is a real seizure, okay? And you have to know when you're going to cause harm, right? So just realize that we treat these as seizures. It's not important for you to be like, oh, this is a pseudo seizure. It's not important, okay? It could be there's variants of seizures. Like I said, they're on a spectrum. And it's very risky for you to write pseudo seizure in your chart. But, you could articulate some pertinent facts of like, the patient guided herself to the floor and was shaking in a relatively organized motion during the seizure. There was no tongue biting. There was no drooling. The patient did not urinate or defecate on herself, right? The behavior stopped when prompted by EMS. So what I was taught in EMS school, and I don't think you should do this, but generally you could tell the patient to stop. And books will even tell you to do this, right? My paramedic book said to do this, to where you could just yell, stop, right? And if you say it authoritatively enough, a lot of times these patients will actually stop, or at least temporarily stop. And that wouldn't happen with a real seizure. You can't stop on command in a real seizure. So what you'll see is if you tell the patient stop, they will stop, and then that would be your cue of like, oh, this probably isn't a real seizure. But again, do no harm, and we treat these as real conditions. And again, don't be salty, don't be cute. Just treat the patient, take them to the hospital. Okay, believe them, trust them, honor our profession. You know, don't be a dick, right? Like that's the rule number one. So, because I've seen paramedics. The reason I'm saying this, guys, I've seen paramedics get real up on their high horse on these, like quit faking, right? And it's just degrading the patient. It's just you're not going to get anywhere, right? You could try to tell them to stop, just treat them with honor. It is what it is. But just realize it's a psychiatric condition if it's a real pseudo seizure. Now, something else called an absent seizure. This is kind of like the lights are on, but no one's home. They're absent. So basically, what will happen is how this stereotypically will present is a patient. It's usually kids, by the way. They'll just stare off in class, and so you'll hear from the parents or the teacher that he seems to just stare off and not be listening, right? And they think that it's inattention when really the poor kid's having a seizure. And so a lot of times how this presents is they just stare off into space. So like lights on, no one's home, they're just staring off into space. And usually they last 10 to 15 seconds at the most. And how this could also present, again, it usually doesn't present with movement, but it could present with lip smacking. That's a common way it's described on exams is they'll say the patient has lip smacking. Okay. So there's no postictal state or confusion with absent seizures. These are a form of generalized seizure because it's across the entire brain, and it can be brought on by flashing lights or hyperventilation. And so when someone gets an EEG, actually a lot of times we'll intentionally inflict this on them. We'll have them blow into like a windmill toy, right, with flashing lights to get them to seize, and we'll trigger an absent seizure to see where it's coming from with an EEG. That's obviously done in the hospital. Okay. No interventions usually needed for this in the pre-hospital environment other than to recognize it and transport them. Now, a focal seizure, remember, this is just a foci. Perhaps a golf ball-sized area of the brain is having a normal electrical activity. You can have focal aware seizures where there's no change in the level of responsiveness, but they could have numbness or weakness, and they could have visual changes, weird tastes or smells, right? And it could or could not cause twitching of the muscles or the extremities, okay? Now, impaired awareness, this could be altered mental status. Again, this will present with lip smacking and eye blinking as well. So that is also, I mean, truly, it's commonly presents with absent seizures as well, where they will do lip smacking and eye blinking, but they will not convulse in an absent seizure, but they can occasionally. Actually, it happens often actually to where they'll lip smack or they'll have eye blinking. Okay, but anyways, they could have unpleasant smells or visual hallucinations. So this is a very difficult diagnosis, by the way, for EMS to make. Just you would say, oh, there's something neurologically wrong. We should take this patient, load them up, and go to the hospital, right? And make sure they don't die between here and there, and support them. Okay. Now there is a condition that I need you to know very well. This is the emergency form of seizures called status epilepticus. And so status epilepticus sounds sophisticated. Means, remember, like status asthmaticus, a prolonged asthma attack? Well, status epilepticus is a prolonged seizure. So the definition is, you need to know this, is a seizure that lasts 4 or 5 minutes or more, or consecutive seizures without return to responsiveness. So I'll say that again. Someone that has a seizure for more than 4 to 5 minutes, status epilepticus. Someone who has a minute-long seizure, stops but never regains responsiveness, has another seizure and never regains consciousness, right? Like that is status epilepticus. So a back-to-back seizures without a regain in consciousness or responsiveness, status epilepticus. Okay? And the reason we need to know about status epilepticus is because this is where true neurological damage can start occurring, because it's recurrent seizures, right? The brain's not able to recover. So they end up having seizure after seizure after seizure, right? And so I've ran patients before. I ran a lady once. Her temp was like 104.4 from seizing for so long. She had brain tumors. She had a seizure for 35 minutes, okay? So she's like near death by the time we got to her. And so just know that status epilepticus, the diagnosis is, have to know this, a seizure that lasts more than 4 to 5 minutes, and or a seizure that is followed by another seizure without a episode of consciousness, or what they'll call a lucid interval in between the seizures. Okay? That's status epilepticus. True medical emergency. Lights and sirens to the hospital when this happens. You got to stop the seizure at this point. And EMTs can't stop it. Only paramedics and doctors can. Now, the neurons are in this hypermetabolic state that's not really important, but basically they're in overdrive, okay? And so the goal of pre-hospital care is to stop the seizure, but you can't really do that as an EMT. And so what we have to do is ensure adequate ABCs and glucose levels, okay? Remember, low blood sugars can cause seizures. So all seizure patients, just like all stroke patients, just like all altered mental status patients, we check up blood sugar, okay? Now, some common causes of seizures are abscesses. An abscess is like a pimple or like a cyst within the brain, okay? That can cause a mass-occupying lesion that will obviously cause a seizure, right? Alcohol, especially high amounts of alcohol, or alcohol withdrawal. Someone who's an alcoholic that suddenly stops drinking, boom, they're going to have seizures, okay? Birth anomaly, of course, brain infections, meningitis, encephalitis, we've talked about that, brain trauma, diabetes mellitus, right? Hypoglycemia, remember the normal blood glucose, 70 to 120. So if someone has a blood glucose level of 30, they can and very likely will seize. They could have seizures, okay? So what do? We fix the low blood sugar and they'll stop seizing. Fever, so there's a rapid rise or a rapid rate of rise too of fever. I will say this, in someone, they have to be less than 5 years old. Okay, they can, if they have okay, let me explain this. It's called a febrile seizure. And so what a febrile seizure is someone who is less than it's between the ages of 6 months and 5 years of age, and they have a seizure because of a fever. Okay, and so it's not a neurological emergency, but they still need to be evaluated by a physician. Long discussion, we'll talk about that in pediatrics. Now, hypertension during pregnancy, so that can progress to a condition called eclampsia. We'll talk about that in OB, obstetrics. Hypoxia, so if the brain gets low on oxygen, the neurons can panic and just start firing off erratic signals. That will cause a seizure. Idiopathic, this is a very common cause. We don't know why they have a seizure. Remember, idiopathic is pathology with no known reason. So it just happens. We don't know why. Inappropriate medication dosage, of course. Organic brain syndromes, of course. Poisoning, of course. Toxicologies, of course. Recreational drug use, especially booger sugar like cocaine, right? So it overstimulates the neurons. Too much dopamine or epinephrine, they start firing erratically. Boom, so this could also happen with methamphetamine, amphetamine, right? Stroke or TIA. So this is what's weird is someone could have a stroke, and of course, hypoxia, there's something happening in the brain. It could abnormally start firing within the brain to lead to a seizure. So this is the reason I think students get stroke and seizure confused because they can overlap, but they are distinct diagnoses that occasionally overlap. Now, sudden withdrawal from alcohol or medications. So if someone's been taking Xanax bars, right, which is a benzodiazepine, for a period of time and they suddenly just stop cold turkey, they will have seizures, guaranteed. Same thing with alcohol. Someone has been killing a 12 pack of alcohol every day for the last 6 months and they suddenly stop today, they're probably going to have a seizure today. So just be aware of that. You'll run that a lot, actually. Systemic infections like sepsis, okay, sure, tumor, we've talked about this, and uremia. So uremia is a buildup of nitrogen products in the blood. And so someone that has poor kidneys to eliminate the nitrogen, the urea, it'll build up to toxic levels and it can cause a seizure. Now, interestingly, I noticed they leave off the most common cause of seizures, and that's going to be epilepsy, okay? So epilepsy is a medical disorder where it will cause abnormal firing of new electrical signals in the brain. And so this is basically probably the single most common cause of seizures in adults and really even probably children over 5 years of old. So basically anywhere from 5 to 100, epilepsy is probably the most common cause of seizures. Now, epilepsy is treated with medications. When we see epilepsy in the pre-hospital environment, is usually because they stopped taking their medications, or they're not dosing it appropriately, or they forgot a dose, or they didn't fill the prescription, or whatever the scenario is. But usually, medication noncompliance is why we get called for epilepsy. Okay. Now, the important thing with a seizure is, especially as an EMT, we can't stop that. There's medications to stop these, right? That paramedics carry, but EMTs can't give that medication. And so, what we have to do is we have to recognize they're having a seizure, and we need to take them to the hospital, right? So, just recognizing a seizure is your task. That's the biggest task. So, recognize when a seizure is occurring and whether the episode differs from previous ones. So, you could use the family as historians. Oh yeah, she has seizures every night. After she eats, they last about a minute. You know, the history of seizures becomes very relevant. And oh yeah, he's been drinking a liter of vodka every day for the past 10 years and he decided he was going to quit today. Okay, well, boom, there's your cause, right? So we want to get a history from the family, of course. Why would they be having a seizure? Have they had seizures before? Are they taking medications? Are they taking them as prescribed? Things like that. Are they followed by a neurologist? When was the last time they're hospitalized? Stuff like that. Now, we got to recognize the postictal state and the complications of seizures. A complication of seizure is airway compromise. Okay, so the patient will often bite their tongue. I've seen people bite chunks of their tongue completely off. So you have to worry about them choking on blood or vomit, okay, or food. Someone could be eating and then have a seizure, and now there's a big chunk of pasta salad in their mouth, right? And they have this big seizure. So, you have to worry about airway compromise. The other thing you have to worry about, I've talked about this, is the diaphragm is not behaving normally in certain types of seizures. So they're certainly almost always going to be hypoxic on top of they just expended a lot of energy. And so, we apply oxygen a lot of times. Remember, the treatment procedures, we don't hold them down. We, make sure that they're safe. We try to keep the dangerous items away from them. We don't put anything in their mouth. And we transport to the hospital rapidly. Okay, and look at other problems associated with the seizure. Now, the postictal state. Remember, the patient will be relaxed. They'll be flaccid, right? And it can be characterized by hemiparesis. This is paralysis of half the body, and that could resemble a stroke. Okay, doesn't mean that we're like, oh, they had a seizure and now they have hemiparesis. It's not a stroke. Hemiparesis is a stroke until proven otherwise. It means we load the patient up and we go to the hospital. Okay. So the most common, this is most commonly characterized by lethargy. The patient will be very confused, so they're going to wake up. What happened? Where are you? What happened? Where am I? Who's here? What's your name? Why are you here? Like the repetitive questioning, right? They're going to keep saying the same thing over and over again. So something we need to do is bring calm to the chaos. If someone's hysterical, maniacal, we remove them from the scene and we let them wake up in a nice, calm environment. Everyone's nice and calm, welcoming, inviting. Okay. Yeah, I've had patients wake up fighting before because I mean, think about this. You wake up and you have two paramedics and three firefighters standing over you. You have no clue what's going on, right? And you're confused and hypoxic. So I've had patients wake up just swinging and fighting with us, and it's okay. Reassure them, hey, it's okay. We're the paramedics. You had a seizure, right? And you're probably gonna have to repeat yourself a dozen times before it sticks, and they're no longer hypoxic and they can understand what you're saying. Now, the patient's condition, if the patient does not condition does not improve, you need to consider it's something else. This should only last 5, 10, maybe 15 minutes at the most. So, with that said, these patients still go to the hospital. So, we don't sit on scene for an hour waiting on someone's postictal state to get better. Okay? Load them up, take them to the hospital. We're in the business taking people to the hospital. That's the right answer on your exam. What your preceptor does in the real world might be different, but we take people to the hospital in this class. Now, altered mental status could also be called AMS, altered mental status. Patient who is not thinking clearly or is incapable of being aroused. Obviously, this could be a cajillion different pathologies or conditions could cause this. This is obviously a sign and a symptom, um, more so a sign. But patient may be unresponsive or responsive but confused. Okay, so there's a lot of different causes, but things that we could rule out or treat: hypoglycemia, hypoxia. And what's hypoxemia? Hypoxemia is low oxygen in the blood, as opposed to hypoxia is just low cellular oxygen. Now, brain infection, again, meningitis or encephalitis, body temperature abnormalities. When people get fever, or even if they're hypothermic, but especially hyperthermic patients, they'll have altered mental status. The brain works in a very narrow threshold of temperature. If it gets too high, it tends to not work well. Unrecognized head injury, okay? So, we may not always get the story that grandma fell and smacked her head in the shower 4 days ago. We might have to look and feel on their head and look for hematomas and bruises to realize, oh wow, she smacked her head. So we have to look for injuries. Severe alcohol or drug intoxication, of course, you're going to get altered mental status with intoxication. Physiological causes and adverse effects of medications. All right, it sounds very similar to seizure, right? What's this word? Say it with me. Syncope, not syncope, syncope. It's the medical word for fainting. So this could be sudden and temporary loss of consciousness with accompanying loss of postural tone. So they'll lose their posture, boom, just fall, hit the floor. Can be a sign of life-threatening cardiac dysrhythmia, like stroke or, other serious medical conditions. So basically what I'm saying, if someone's heart rate goes from beating at 70 times a minute to 20, even if it's temporary, they're going to pass out. They're going to faint, right? Not enough oxygen's going to get to the brain. It's going to stop working and they're going to fall. So that would be syncope, okay? Lots of causes of syncope. Low blood sugar, stroke, cardiac arrhythmia is probably one of the more common. Low blood pressure, it's very common, right? Psychogenic shock, right? Moral disgust, right? Someone seeing blood or something like that, they could pass out. So anyways, again, issues with the heart attack, dehydration will cause low blood sugar or a low blood pressure. So they will pass out. Where you'll see this most commonly is they'll pass out upon standing when their blood pressure is low. Hypoglycemia and a vasovagal episode. This would be like someone who's like watching surgery or something like that, or looking at blood or something like that, and they just pass out. Okay. Now, moving forward to headaches, we're almost done. Headaches, you don't need to memorize this part, but headache, there's three different types that they want you to know, and the most common one is a tension headache. We've all had this. You get this from EMT school, where it's from stress, okay? And so basically, we get this from stress, depression, they even say cortisol levels, but really it's stress. I want you to think tension. You're all stressed and tense, right? Tension headache. And so it's basically from overusing muscle contractions in the face and the head. And so sometimes when we're stressed or angry, we kind of bear down and we're just all tense and shit all day, right? That can cause a tension headache. And it's usually a band-like distribution across the head. We've all had that. Now, migraine's different. This typically affects females, but it can affect anyone. But it typically females. And so it's very complicated migraine, the diagnosis, but you could know that there are treatments that deal with like serotonin and different neurotransmitters that we tend to target. But the thing about a migraine is they tend to be unilateral and piercing, right? Like they tend to be very painful. And they can also present with an aura, by the way. So they might start smelling pennies or tasting pennies in their mouth, and they're like, crap, I'm about to have a migraine, right? So they can present with aura, just like a seizure can. And so it tends to be unilateral, like the right side of their head hurts, or the usually it's one side of the head. Now, the last one's a cluster headache. This is rare, but these are very painful. This is typically men, actually middle-aged men, that what will happen is they'll get lancinating pain behind one eye that usually will wake them in the middle of the night. It's called a suicide headache because it's that painful they would rather die. And so the classical vignette is someone who wakes up in the middle of the night with extreme pain behind one eye. Okay, especially a man. So if they tell you, 29-year-old male wakes up, extreme pain, 10 out of 10 pain, crying in pain, and he has extreme pain behind his right eye with lacrimation, right, tearing of the eye, or salivation even, but especially lacrimation, tearing of the eye, it's a cluster headache. Okay. Now, the brain is very sensitive. I keep saying this, so this is the part where I zoom through. It's very sensitive to oxygen, glucose, and temperature. So if any of those get out of whack, high or low, in any direction, it doesn't work very well, and it'll manifest, okay? So the good thing is we can fix oxygen, glucose, and temperature as an EMT basic, right? So we look for these. So this becomes from our vital signs. We check oxygen, SpO2, glucose, blood glucose levels, right? Finger stick glucose reading. Temperature, temporal artery scanner, right? So we check these things. These are part of our vital sign assessments. So all altered mental status patients, all of them, seizure, stroke, anything to do with the brain, if the pathology of the brain is involved, you need to get a temperature, a blood glucose reading, and a pulse oximetry reading, always. Bare minimum. Take standard precautions, right? If the nearest stroke center is more than 1 hour away, you could consider, this is controversial, you could consider flying the patient, okay? Now, we form our general impression. Remember, this would be decorticate posturing. This would be decelerate posturing. How do you know the difference, Hunter? Because the decor is protecting up in the core, right? So they're up near their core. They're at their chest, okay? So just know this is called posturing. I've told you. What type of stroke do we see posturing in? Hemorrhagic stroke. Remember, this is the one where they get worse and worse and worse, and they die. If you see a patient like this that told you they had the worst headache of their life, they have a hemorrhagic stroke and they're on their way to dying. So it's very bad when this happens. Remember, this is part of our GCS scoring, right? We use this. Now, we focus on the airway. Remember, if someone's brain's not working for whatever reason, we have to be worried that they can't protect their airway or that their brainstem is going to get affected to where they might not breathe effectively. So follow this algorithm. Make sure the airway is patent, i.e., they don't have pizza and vomit in their mouth. If they do, we suction it, okay? Make sure that the airway is patent. Provide suction and position the patient to prevent aspiration. If a patient has, a seizure or if they're unconscious, we put them in recovery position. We roll them on their left side. So if they vomit, the blood will come out, or the vomit will come out of their mouth. Provide ventilatory support at a rate of 10 to 12 breaths per minute. So again, if they tell you the patient is breathing 8 times a minute, we ventilate. We use a BVM. We put the mask on their face, do the CE clamp, and we do a BVM, okay? Circulation. If no pulse is found, especially a carotid pulse, we immediately begin cardiopulmonary respirations or resuscitation. Well, Hunter, what if they're breathing 10 times a minute? But if the vignette says they do not have a carotid pulse, you start CPR. No pulse, they're dead. Start CPR. Transport decision. This becomes difficult. It's going to depend where you work. Sometimes I decide to take patients to Weatherford. Sometimes I have to decide to drive even further to go to Fort Worth. It really kind of depends on where I'm at and what's wrong with them. Your protocols will guide you where you take these patients and when. It becomes very complicated for stroke care. I'm actually speaking at a conference in May on this with where do you take these patients, right? And so there's this whole complicated algorithm that we don't need to know right now for the National Registry. But if you want to work in a system, you'll have to learn it. Now, we take good history. Remember, the family, the scene, the medication list, what you observe, the context clues. You get that. The physician doesn't get that, right? So you have to play detective and gather all that for us, okay? Ask the family, the bystanders, look around the room. Oh, wow, there's an empty bottle of Xanax next to the patient. It's probably a Xanax overdose, right? Oh, it was filled today and there's 30 pills missing, right? So, we use our context clues to look around. You get that. We are relying on you, the healthcare system, the patient is the EMT, to use the scene and gather and extract data and bring back that to the hospital. Okay? Look for trauma. Just because you get called to a stroke doesn't mean they didn't fall down and have a stroke, right? Just because you get called to an altered mental status doesn't mean that they have an altered mental status because they fell and smacked their head, right? Or they fell and bang their stomach on the edge of a counter and now they're bleeding in their abdomen, right? So what I'm saying is, altered mental status is very well a sign and symptom of trauma. So just be aware of that. So you're going to do your secondary assessment. You're going to perform it as soon as possible, right? Uh, you're going to look for injuries. You're going to rapidly identify if it's a stroke, very rapidly, and transport even more rapid to the most appropriate stroke facility. So we talk about common stroke tools. We're going to show you the Van stroke tool and the Be Fast stroke tool in class. You'll become familiar with this. We'll do this on each other. Okay, the assessment. You will be very good at that. Uh, so basically, we again, heart rate, blood pressure. You get a full set of vital signs on these, right? Heart rate, blood pressure, respiratory rate and pattern, pulse oximetry. If your system allows it, remember end-tidal CO2, where we measure the amount of carbon dioxide that's breathed out through the nasal prongs. Glucose monitoring, temperature monitoring, GCS scoring, alertness scoring, alert and orientation scoring, pain scoring, right? All those things. We're getting all of that. This is the whole shebang on neuro patients. You need to get everything. Again, we're limited to what we can do as EMTs, but sometimes we just provide emotional support. We let them know, hey, we're here with you. We're going to take good care of you. We're going to take you to the hospital. Do you have any questions? How can I make you more comfortable? I like to ask patients every time I transport them, is there anything I can do to make you more comfortable, right? Because it could be something simple like, can you dim the lights? Can I get a blanket? Can you adjust the stretcher? Whatever it is, right? And it's easy fixes that these are human beings that we owe that to them, right? So just be aware of that. Now I've talked about the medications, but I'm gonna run through these really quick, okay? Or I'm sorry, the medications, the treatments. So let's talk about the medication for hypoglycemia, which is really an endocrine disorder, but it'll present with altered mental status or it could mimic a stroke or a seizure. Um, the treatment is going to be for us oral glucose. Remember oral glucose? You put it in the buccal cavity of a patient who is alert and can follow your commands. We put it in their buccal cavity. Okay? But they have to be alert and follow your commands. Why is that? Because if they're alert and following your commands, we assume that they have an intact gag reflex so they can protect their airway. The paramedics will give a medication through the IV called D50. We do not as EMTs. So just watch for that. But we want to make sure that the patients do not aspirate. What's aspiration? It's when they choke on their vomit or spit or blood or whatever. They choke on something. It goes down the trachea into their lungs. It's very bad when that happens. Guaranteed ICU admission. Now, stroke, remember, the job is to recognize stroke, gather the medications, gather the clues, and transport rapidly, right? So have a quick on-scene time and go to the hospital quickly. And so I told you this, assume that a patient with what you think might be a TIA or stroke symptoms is experiencing a stroke. Let me tell you another way TIA will present. You're called to a scene for a stroke. You get there and the patient looks like me, talking like normal, talking fast, moving all his extremities, no stroke symptoms. But the patient and or the patient's family tell you his whole face was sagging for 10 minutes and it's a 20-minute response time and it resolved 5 minutes ago. It's still a stroke. Load him up, take him to the hospital. It's an emergency. Okay? Take him to the hospital. So realize just because the symptoms resolved when you got in scene or if they resolve in front of you, it's still an emergency. Take him to the hospital. So we might need to administer supplemental oxygen if the O2 sats are 94% or less, right? You're going to want to elevate the head of the bed 30 degrees, right? So if this is the stretcher, right, you're going to want to elevate it like that, like 30 degrees. Now, ensure that the airway's clear and watch for seizures, okay? You might want to call for a paramedic backup, but don't delay that. Don't delay your transport to meet with paramedics, because even paramedics are very limited for what we can do on stroke. They need to go to the hospital and get the life-saving medication. There's an algorithm here that I will actually run through really quick. So basically what happens is, as the EMS, right, we have to determine that there's a stroke, right? So we do our physical, and we have to figure out what's called the last known well or the last known normal, okay? So we're going to ask the patients or the patient's family, when was the last time you saw them normal, right? And I don't like using that word. When was the last time they were well, right? And so they'll say, oh, it was when they went to bed last night, and you got the call at 7 in the morning. Well, the last time they were normal was at 9 p.m. last night when they were when they were seen normal. Even if they had the stroke at 4 o'clock in the morning, doesn't matter, right? It was the last time they were seen normal. That's a very important piece of information. So when was the last time they were talking normal and their speech wasn't garbled and they didn't have droop or whatever, okay? You're going to check the blood glucose level. You're going to start transporting to a stroke center, right? And you're going to notify the stroke center that you're coming in with a stroke. You're going to alert them. It's called a stroke alert, okay? When you get to the hospital, they're going to end up scanning the patient's head with a CT to look for bleeding. If they're going to start an IV, right? They're going to manage them. If there's no bleeding within the brain, we give that clot busting drug. The reason we have to scan their head first is if there's bleeding, you obviously don't want to give a drug that causes clots to bust, because those clots are holding to, they would bleed more basically. So you got to scan their head real quick with a CT, a CAT scan, and make sure they're not bleeding. And then, if they're not and they're within the time window of about 4 to 5 hours, or 4.5 hours from last known well, we give them this drug called Alteplase. That's the trade name of TPA. And so basically we give that, and then they hopefully get better. Now, there is a scenario where in Fort Worth, they have something called thrombectomy, where basically if someone has a really big clot up in their brain, you can take a special machine through the vessels. Let's just say the vessels of the neck. It's not, but the vessels of the neck. And you can go up there and grab that clot and pull it out, like literally mechanically. Go in there with some fingers and grab it out with a machine and extract it. And so obviously that's very advanced when that happens, but it does happen in about a quarter of strokes, or they can get that. So just be aware. This algorithm, don't spend a whole lot of time memorizing it. I'm just trying to explain it to you. Of how this happens. What we need to know is we recognize a stroke and we transport, right? Remember, TIA, it's the same guidelines as a stroke. So even if the vignette or the question I give you on a test clearly prints it as a TIA, it's still treated as a stroke. You observe them, you transport them rapidly to a stroke facility, right? It's a warning sign, okay? Remember, 70% of TIA patients, if left untreated, will have a stroke in the coming 48 hours, okay? They're going to have a stroke. Or no, they'll have a stroke within the coming week. So 70% of patients with a TIA, if left untreated, they'll have a stroke within the coming 7 days. Remember, the thing about stroke, again, is that they don't heal. So ask yourself this. When someone has a big O stroke in the right side of their body, they can't feel it, they can't move it, their speech is garbled, the memory is impaired, right? Their thought function might be impaired. Do you think they go home? They don't. They go to a nursing home and they die there, right? It's very sad. It's a very sad disease, very expensive disease on the healthcare system too, because these patients require a lot of continuous care for the rest of their life because they never go back to normal. And so that's why we have to treat TIA and stroke so seriously, is because they will never get better again. They will never go to their grandkids' softball games. They will never crochet or cook again, right? Like, they don't get better. So we got to be very aggressive with treating strokes. Take them very seriously. Almost done. 2 more slides. Seizures. Remember, patients need definitive treatment and evaluation at a hospital. So on your exams, I don't care what your preceptor says. On your exams, at least, transport them. You might see in the real world someone who has a history of epilepsy. They might refuse to go, called an against medical advice. They'll refuse to go to the hospital. This is in the field, but it won't happen on your exam. So if someone has a seizure history or not, we take them to the hospital on exams, and really in the real world, you should too, okay? Remember, we administer oxygen if their SATs are less than 94%. It commonly will be in the postictal state, so throwing on a breather on them is typically what I do. Suction the airway if needed. Remember, their swallowing will be impaired, and especially if they bite their tongue, they'll be bleeding. So we might have to suction blood or spit out of their mouth or vomit, okay? You might have to provide positive pressure ventilations. So if the vignette tells you they're breathing 38 times a minute and shallow, then you need to pull out the BVM and start ventilating on them. And I know you're thinking, there's no way you're going to stick a BVM on a seizing patient and ventilate them. I agree. I'm not the one that comes up with this stuff. It shows up on exams. So again, if someone has impaired breathing, ventilatory rate, we tend to jump to a BV or to using a BVM. Not my opinion. It shows up on exams all the time. Remember, syncope is the medical word for fainting. So determine if the patient experienced trauma during the fall. If they did, we might need to put them in a cervical collar, right? Especially if they smack their head. Take C-spine precautions. Focus on blood glucose levels and in cardiac causes. So if someone's heart rate is 235, right, it's probably cardiac cause that caused them to have syncope. So they need to go to the hospital. So check for that. Provide supplemental oxygen and provide fluids as appropriate. Remember, syncope is not benign. I mean, it can be benign, right? It can be like nothing, but we don't make that assessment as EMTs and paramedics. Take them to the hospital, right? They need to be evaluated. That's serious because if they're driving and have a syncopal episode and go head on and kill someone, that's a problem. If they're walking in the middle of Walmart and they fall and smack their head and crack it open and die, right? That's a problem. So you got to take these serious. They need to still be evaluated, even though syncope is a pretty common complaint. We get it a lot. Okay. And I will say, let me say something about syncope. There's something called near syncope, which sounds like exactly what it sounds like. They nearly fainted. They nearly passed out. So no, that's a diagnosis that you might see sometimes. So if they tell you the patient almost passed out, right? It's called near syncope. They nearly passed out. Okay. So that's it for neurological. This obviously can be a very complicated chapter, but we have to keep it at the EMT level and only hit what we need. Oh, what we only need to hit headache. It's supportive care. Okay. Be careful doing like noxious things like lights and sirens or like having the lights in the ambulance on full brightness or listening to music or talking real loud or whatever, right? So all those are aggravating factors for most people's headaches. So we've all had headaches. What do you not want? Noxious stuff, right? Smells, stuff like that can be very noxious. So just be aware of that. Okay. That's it for this lecture. I appreciate y'all's time.